Human anatomy and physiology. Here we are in episode 4 with a continuation of our lectures on the respiratory system. In this particular episode, we'll start to speak to the mechanism of breathing, including some key principles, as well as some of the major muscle groups which may or may not be involved, depending on whether breathing is considered to be more of a passive or quiet type of activity versus a more active or forceful type of activity. So if you think on a day-to-day basis, oftentimes breathing will occur without that kind of conscious input, and oftentimes it just happens automatically. And we're really talking about forceful or active type of breathing when we're engaged in lots of exercise, or if you consciously decide to inhale or expire air more forcefully, for example, during a pulmonary function test. So let's get started. So on the first slide, what we see is a very general kind of overview of normal inspiration and expiration. And so essentially, these processes occur due to an expansion or contraction of the thoracic cavity. And so that's what we're looking at here with the ribs and the lungs. If we look at the diagram on the left of the screen, we're looking at inspiration, and that's the process by which we're going to be breathing and taking air into the lungs. In this case, the thoracic cavity will expand to increase the volume, and as a result, the pressure inside of that space decreases. What you can see is that there are a couple major muscle groups that are involved in inspiration, and once again, it will depend on whether it's quiet or more forceful type of breathing. So we have our external intercostal muscles, which can contract in some cases, but not always. And we also have the diaphragm. So the external intercostal muscles are those small little muscles that exist between adjacent ribs. So you can see the small arrows highlighting where those muscles would be. And then the diaphragm is that dome-shaped muscle that basically transcends and divides off the thoracic cavity from the abdominal cavity. Now, during inspiration, what you can see is that dome-shaped diaphragm is going to descend or as it contracts, so it's going to move downward. And that is going to increase the overall volume or space within the lungs. And as a result, anytime you have more space, it is going to have a resulting decline in pressure. In contrast with expiration, the thoracic cavity is now relaxed. There's a smaller volume, and as a result, anytime you have a smaller amount of space or volume, it's going to increase the pressure. In this case, what you can see is the diaphragm is relaxed, and there is a dome-shaped the diaphragm is essentially dome-shaped, and those external intercostal muscles will now be relaxed, and air is going to make its way out of the lungs. And so with the respiratory cycle, there's this constant alternation between inspiration and expiration. And we've been talking about that relationship between pressure and volume, and that really is the key principle of ventilation, and it's known as Boyle's law. So we will come back to it as we proceed through this lecture, but that relationship between pressure and volume and how they are inversely proportional to each other is Boyle's law. There's two other concepts that I'll highlight just briefly. The compliance, so our tissues can be compliant in that the lungs have an ability to stretch, and that is going to help determine the ease in which we take in air, so the ease of inspiration. There's also elastic recoil, and that also exists within our tissues. And in the case of the lungs, that's the tendency of the pulmonary tissues to return to a smaller size after having been stretched out. And that is going to determine the ease of expiration. So elastic recoil, that tendency for the pulmonary tissues to return to a smaller size during expiration. So here what you can see is just an overview of pulmonary ventilation with the alveoli at the top and the venous and the atrial system highlighted in blue and red respectively as we bring oxygen in through the alveoli into the circulatory system. It travels through the circulatory system and we can see the partial pressures of oxygen and CO2 respectively at these different areas. So at the alveoli, the partial pressure of oxygen, for example, is 100. The partial pressure of CO2 is around 40 millimeters of mercury. As oxygen makes its way through the body and towards the tissues, you can see that oxygen is able to make its way out of the circulatory system and to the cells. And at this point in time, the pulmonary or the partial pressure of oxygen now is less than 40 millimeters of mercury, and the partial pressure of CO2 is greater than 46 millimeters of mercury. And so CO2 is favored to go back into the circulation and make its way to the lungs, where it can be offloaded to the alveoli and back to the external environment. And so once again, this is just a broad overview of pulmonary ventilation, that act of breathing with the movement of air into and out of the lungs. And the major mechanisms that drive pulmonary ventilation are actually atmospheric pressure, or the air pressure within the alveoli as well. And that's called the intra-alveolar pressure. And so that's what we were talking about when we saw that partial pressure of oxygen around 100 and the partial pressure of CO2 around 40. And this is a cyclical type process, as I mentioned, with the respiratory cycle. Pulmonary ventilation is comprised of both inspiration and expiration, as we saw on the preceding lecture slide. Next, moving on to Boyle's law. So this is that primary principle of ventilation, talking about that inverse relationship between pressure and volume. So anytime you have a gas, the pressure will increase as the volume decreases. What we're looking here is just a schematic diagram, essentially showing you a container and showing you gas or particles in that container. And as the volume increases, or that space in the container increases, there's more room for those gas molecules or those particles to move around. And so that's the pressure will decrease. That is symbolic or representative of inspiration, as we saw in the preceding slides. Conversely, as volume decreases, the pressure will increase, as highlighted in the diagram on the right of your screen. And that is really symbolic or representative of expiration. And once again, there's less room for the gas to move around. And so you can kind of think about this in terms of being on a subway or a public transit on a bus. Anytime, for example, if there's not a lot of people on the bus, you feel like you have lots of room. It doesn't feel as like anxiety provoking or as much pressure to maintain a certain space. It's nice in a relaxing environment versus anytime you're squeezing onto the bus or onto the subway, there's a lot less space and the tension or the anxiety of being so close to other people is anxiety provoking and creates a lot more of a high pressure situation. And so that symbolic or representative on that of the diagram on the right. That's how I like to think about it. Notably, I just want to also highlight that, as I mentioned with Boyle's law, the volume of gas varies inversely with its pressure at a constant temperature. Air will move from a region of higher pressure to one of lower pressure. And so once again, that's if we think of an analogy for that, for example, if you have a series of subway cars and most of them are filled with people, it feels so much better when you hop off and you go to a different subway car that happens to be empty. So air likes to move from a region of higher pressure to one of lower pressure. Also, it's important to note that atmospheric pressure is constant at a given location. So what's really controlling the direction of airflow when we think about the lungs is the alveolar pressure. And so if the size or the volume of the thoracic cavity is altered, then the pressure of the thoracic cavity is also changed, but in the opposite direction. And so that's what we're looking at here as well on the screen. So as an example, if we take inspiration, or that schematic diagram on the left of your screen, if the size or the volume of the thoracic cavity increases, then the pressure of the thoracic cavity, known as your alveolar pressure, will actually decrease. And that is going to facilitate air coming into the lungs or moving down that kind of concentration gradient as we highlighted. So air likes to move from a region of high pressure to one of low pressure. So here we have another diagram highlighting these pressure relationships. So the intraalveolar pressure is the pressure of air once again within the alveoli, and that's going to change during the different phases of breathing and really drive bringing air into the lungs and out of the lungs as well. As we mentioned, at a given location, the atmospheric pressure is the same. So once again, it's going to be the alveolar pressure which drives bringing air into and out of the lungs. Because the alveoli are connected to the atmosphere via the tube of the airways, what you can see in the center of your screen, the intrapulmonary pressures of the alveoli will always equalize with the atmospheric pressure. Similar to the intraalveolar pressure, we also have intrapleural pressure, or the pressure that exists between the visceral and the parietal pleura, as we highlighted those structures in preceding lectures, but you can see them at the top right of your diagram. Although it can fluctuate during inspiration and expiration, I should say, intrapleural pressure will remain slightly negative. So it can remain around -4 millimeters of mercury throughout the breathing cycle. So let's go on to now looking at inspiration versus expiration. So we have quiet inspiration, which is shown on the screen here. And then on the next slide, we'll look at forceful inspiration before moving on to expiration. So anytime we're bringing air into the lungs, we have the diaphragm muscle, and the diaphragm muscle contraction is needed to bring air into the lungs. It will descend, the thoracic cavity becomes larger, and as a result, there is more volume and the pressure drops. Anytime the alveolar pressure declines, it is going to decrease significantly and allow air to move from a high pressure to a low pressure environment. Air will move into the lungs as a result until the pressure in the lungs equalizes. And at that point in time, the movement of air into the lungs will stop. In contrast with forceful inspiration, or when we're really trying to actively bring air into the lungs, you may actually recruit additional muscles. And so in addition to the diaphragm, which is that broad dome-shaped muscle that transcends and really divides the thoracic and abdominal cavities, you also have additional muscles like accessory muscles that can assist in the process of breathing. And those include the external intercostals, the sternocleidomastoid, the pectoralis minor, and the serratus anterior. In each of these cases, it helps, these muscles help to expand the rib cage and help to elevate the sternum and enlarge the thorax, once again, allowing for the thoracic cavity volume to expand. And as a result, you have a further decline in pressure, and that is going to further encourage air to come into the lungs. This is in contrast to quiet expiration. So quiet expiration, so during normal quiet breathing, only the relaxation of the inspiratory muscles are required. There's actually no need for the contraction of the expiratory muscles. And you also have elastic recoil, or that tendency of the pulmonary tissues to return to a small size after they have been stretched, and that occurs passively. So with quiet expiration, once again, you now have the doming of the diaphragm as it relaxes, and therefore there is a decrease in the size of the thoracic cavity, and as a result, less volume of the thoracic cavity, and that will lead to an increase in pressure. When the alveolar pressure exceeds that of the atmospheric pressure, air will move from higher pressure to lower pressure, and therefore from the lungs to the atmosphere. Enough air will move out of the lungs such that the pressures equalize, so the alveolar pressure and the atmospheric pressure will equalize, and the movement of air into or out of the lungs will stop at that point in time. This is in contrast to forceful expiration, where we are actively trying to get air out of our lungs. So during, for example, a pulmonary function test, individuals or patients are asked to breathe into a tube, and you're asked to forcefully exhale as much air as you can in 1 second. And so that's an FEV1 type test. And so you're forcefully exhaling a lot of air in a short period of time. And so to do that, you have additional muscles in addition to the relaxation of the diaphragm that can help with that. And that includes the internal intercostal muscles as well as the abdominal muscles. This is going to result in a further decrease in the thoracic volume. And once again, this speaks to Boyle's law, that inverse relationship between pressure and volume. That is going to allow for more air to move out of the lungs. Now, there are additional factors that influence breathing. So you can think about low levels of oxygen, high levels of CO2, decreases in blood pH. There's also cerebral cortex control, blood temperature, cold stimuli, pain, and pharynx type receptors during choking, for example. Many of these factors can also modulate breathing as well. And so in the pharynx, for example, we have sensory receptors, and so it triggers a choking reflex, which prevents the aspiration of foods or liquids, and as a result, to try to maintain an open airway to promote breathing. So these are all factors which will influence breathing.